Welcome back to the deep dive. You know how it works. You send us what's rattling around in your brain, and we help you nail it down.
That's right. And today, we're tackling your revision notes on polymyalgia rheumatica, PMR for short.
PMR. Got it.
Think of this as, well, a really efficient way to lock in the key facts. Whether you're a healthcare pro needing a quick refresh or, just curious.
Right. So our mission today is to get everyone totally comfortable with PMR. Definition, causes, who gets it, how it shows up, diagnosis, treatment, the works.
Yeah.
Basically make recalling PMR easy.
Exactly. High-yield recall.
Okay, let's dive in then. What exactly is polymyalgia rheumatica? Give us the nutshell version.
Okay, so PMR, basically it's an inflammatory condition. It causes muscle pain and stiffness.
Pain and stiffness. Where specifically?
Mostly the shoulders and hips. Those are the key areas.
Shoulders and hips.
And here's a really important link. It often hangs out with temporal arteritis. That's inflammation of blood vessels in the head.
Right. Temporal arteritis.
Yeah.
So they can occur together?
They can. And sometimes PMR can occur alongside giant cell arteritis or GCA. Think of them as related conditions.
GCA, okay.
Another key thing, it's common in older people, say over 50. And the good part is it usually responds really well to steroid treatment, corticosteroids.
Steroids, okay. But what causes it? Do we know?
Well, that's the tricky part, the precise trigger, the etiology. It's still a bit elusive. We see the inflammation, but the why isn't fully pinned down.
So the body's inflamed, but the reason, it's a question mark.
Pretty much. The leading theory is it involves an abnormal immune response.
Like the immune system gets confused.
Exactly. Sort of turns on the body's own tissues. And there's probably a role for genetics too, plus maybe environmental factors, things that might make someone more susceptible.
Right. Okay, so if genetics and maybe environment play a part, who's actually most at risk? What are the main risk factors?
Yeah, good question. The biggest one by far is age. Like I said, PMR mainly hits people over 50.
Over 50, that's a clear marker.
Definitely. We also see it more often in women compared to men.
Women more than men. Okay. Anything else?
And interestingly, there's a higher prevalence noted in people of Northern European descent.
Northern European.
Yeah, so if you were making a quick mental note, it might be older, female, Northern European. But, of course, it can affect anyone.
Okay, that paints a clearer picture. So we know what it is and roughly who gets it. Let's talk about the how. What's actually happening inside the body? The pathophysiology.
So the main action is inflammation in the synovial tissues.
Synovial tissues. Those are the joint linings.
Exactly. The tissues that help joints move smoothly. In PMR, these get inflamed, particularly around the shoulders and hips.
So that's the source of the pain and stiffness.
Precisely. That inflammation causes the pain, the stiffness, and makes it harder to move those joints freely.
Is it just inflammation or other things involved?
Well, on a deeper level, you've got various immune system players involved, things called cytokines, they're like messenger molecules, and different immune cells, plus even some changes in the small blood vessels in those areas. But the core issue, inflammation in those joint linings.
Got it. Inflammation in the synovium. Now, if someone comes in with shoulder and hip pain and stiffness, it sounds like it could be a few things, not just PMR.
Oh, absolutely. That's crucial. The differential diagnosis is pretty wide. We need to think about what else could be causing these symptoms.
How you usually break that down?
It helps to group them. You can think about other inflammatory disorders and then non-inflammatory ones.
Okay, let's start with inflammatory. What else is on that list?
Right. Well, a big one is rheumatoid arthritis, RA.
How's that different?
RA often hits smaller joints like hands and feet more symmetrically. Plus, the blood tests can show different markers like rheumatoid factor or anti-CCP antibodies, which are usually negative in PMR.
Okay, RA.
Then you've got things like ankylosing spondylitis that mainly affects the spine, psoriatic arthritis, often seen with skin psoriasis,
Right.
lupus, systemic lupus erythematosus that can affect, well, almost any organ, scleroderma, which involves skin hardening, Sjogren's syndrome, known for dryness, like dry eyes, dry mouth.
Keep going.
Various types of vasculitis, that's blood vessel inflammation again, like GCA, but sometimes other types. And also dermatomyositis and polymyositis.
And those affect muscles too.
Yes, but they typically cause true muscle weakness. That's a key difference. Remember, PMR is primarily pain and stiffness, not significant weakness.
Stiffness, not weakness. Got it. That's a really useful distinction. Okay, what about the non-inflammatory conditions that could mimic PMR?
Right, that list is long too. You've got your classic osteoarthritis, more wear and tear joint issues,
Makes sense.
spinal spondylosis, age-related changes in the spine, rotator cuff problems or frozen shoulder joint. Those
Okay.
are specific to the shoulder joint, not usually bilateral hip and shoulder like PMR.
Okay, more localized things.
Exactly. Then, drug-induced myalgia muscle pain from meds. Statins are a common one to think about.
Ah, statins, right.
Infections need considering too. Viral illnesses, sometimes bone infections like osteomyelitis, or even heart valve infections, endocarditis or TB. They can cause generalized aches.
Wow, okay. Infections.
Malignancy is another important one to rule out. Certain cancers like lymphoma, leukemia, myeloma, or cancers that spread to bone like lung or prostate can present with pain.
Gosh, yeah. Serious stuff.
Other possibilities.
Yeah.
Amyloidosis, Parkinsonism, though, that's more about movement disorder. Chronic pain syndromes like fibromyalgia. Even depression can sometimes manifest physically.
Fibromyalgia, depression.
And finally, endocrine problems or metabolic bone disease. Things like thyroid issues, overactive or underactive thyroid. Parathyroid problems.
Yeah.
Osteomalacia, which is soft bones, or even pseudogout.
That is quite a list. Really highlights why you need to investigate properly.
Absolutely. You can't just assume it's PMR based on shoulder and hip pain alone.
Okay, so we know it's important to diagnose carefully. How common is PMR? You mentioned it's common in older adults.
Yeah, it's relatively common, especially here in the UK. The numbers suggest around 52 new cases each year for every 100,000 people aged 50 and over.
52 per 100,000 over 50.
Right. And it gets more common as people get older, really peaking around the late 60s, early 70s. The average age it starts is about 73.
So really an older person's condition.
Predominantly, yes. If you look at the lifetime risk, it's estimated at roughly 2.4% for women and 1.7% for men.
Still higher in women, though.
Yes, that holds true. And again, more common in those with North European roots, but it can definitely affect people of any ethnicity. Key takeaway.
Yeah.
It becomes much more likely with increasing age.
Okay, so clinicians really need this on their radar for older patients with aches and pains. Let's get into the specifics of how it presents. What are the classic clinical features?
The absolute classic is that bilateral pain and stiffness, both shoulders, both hips.
Bilateral.
Both sides.
Yes, and it's often this deep aching feeling. Crucially, it's typically much worse in the morning or after you've been resting or inactive for a bit. That morning stiffness again? How long does it last?
Usually quite a while, often more than 45 minutes. That prolonged morning stiffness is a big clue.
Over 45 minutes. Okay.
Patients might also feel generally unwell. Things like significant fatigue, maybe a low-grade fever, losing weight without trying, just feeling blah, malaise.
Systemic symptoms too.
Exactly. And often these symptoms come on quite quickly, maybe over a few weeks rather than creeping up slowly over years.
Rapid onset. Right.
So the typical picture is someone over 60, maybe 70s, rapid onset of this bilateral shoulder and hip girdle aching, and significant morning stiffness. And remember, aching and stiffness, not usually true muscle weakness.
Stiffness, not weakness. Hammering that home. Are there other things you might hear from patients?
Sometimes, yeah. They might mention some milder pain in other joints too. Low energy is common, sometimes even symptoms of depression, loss of appetite, maybe night sweats occasionally.
Okay. So if you're seeing a patient over 50, what really makes you suspect PMR? What are the criteria?
The key things raising suspicion are that severe, persistent pain in the neck, shoulders, and pelvic girdle area, the morning stiffness lasting over 45 minutes, and then evidence from blood tests of an acute phase response, meaning raised inflammatory markers like ESR or CRP.
Oh, okay. So pain pattern, stiffness duration, raised markers, older patient.
That's a good summary. And that bilateral shoulder pain and stiffness on waking is really a hallmark feature.
Gotcha. And you mentioned needing to rule out other serious things?
Absolutely critical. You have to exclude active infection, cancer, and especially giant cell arteritis, GCA. Always think GCA.
Because of that link you mentioned earlier.
Yes. So you need to specifically ask about and look for GCA symptoms, new headaches, scalp tenderness, jaw pain when chewing, any visual changes. Those are red flags for GCA.
And does GCA need treating differently?
Urgently. If you suspect GCA, that needs high-dose steroids immediately. The PMR diagnosis itself can sometimes wait a little bit while you focus on ruling out or treating GCA if it's suspected.
Right. Urgent GCA assessment.
And you also need to actively check for signs of those other differentials we listed, like examining for swollen lymph nodes or checking the thyroid gland. Rule out the bad stuff first.
Okay. So it's clear diagnosis isn't just based on symptoms. What investigations do you actually do?
It's definitely a combination. The patient's story, the physical exam, and lab tests.
Lab tests being key.
Very key, especially blood tests for those inflammatory markers, ESR, erythrocyte sedimentation rate, and CRP, C-reactive protein.
ESR and CRP, are they always high?
Usually, yes. They show that underlying inflammation. CRP is often considered a bit more sensitive than ESR and PMRs.
CRP more sensitive. Okay. What about scans, X-rays, ultrasounds?
Imaging isn't typically used to diagnose PMR itself. It's more about ruling out other conditions, like checking for osteoarthritis on an X-ray or using ultrasound to look for shoulder problems like bursitis.
Makes sense. So what's the standard list of blood tests you'd order initially?
Okay, the essentials. Definitely ESR and CRP. A full blood count, FDC, urea and electrolytes, UNEs for kidney function, liver function tests, LFTs.
Standard baseline stuff.
Pretty much. Also a bone profile calcium phosphate, protein electrophoresis that helps look for things like myeloma, thyroid function tests, TFTs.
Right, ruling out thyroid issues.
Creatine kinase, CK, that muscle enzyme. It's usually normal in PMR, helping distinguish it from conditions causing muscle damage.
Normal CK.
Yeah.
Again, stiffness, not weakness.
Exactly.
Yeah.
Rheumatoid factor, RF, to help rule out RA, and a urinalysis. It's a fairly broad screen.
Okay, that's the core set. What about those additional tests you mentioned? When do they come in?
You'd consider those if the picture isn't quite typical or if you're still unsure after the first round. For example, testing urine for Bence-Jones protein if myeloma is still a possibility.
Okay.
Maybe more specific autoantibodies like ANA or anti-CCP if you're strongly considering lupus or RA. A chest X-ray, CXR maybe if there's concern about lung issues or cancer.
In ultrasound.
Yeah, ultrasound of the shoulders or hips can sometimes be useful. It might show things like subdeltoid bursitis or inflammation around the biceps tendon or synovitis in the joint. Signs consistent with PMR, but again, mainly used if diagnosis is tricky or to exclude other local problems.
Right, so a very thorough workup is needed. Okay, you've diagnosed it. How do we manage PMR? What's the treatment?
The cornerstone of treatment is low-dose corticosteroids. Prednisolone is the usual one.
Prednisolone, low dose.
Relatively low, yes, compared to what you might use for GCA, for instance. And they are usually remarkably effective at controlling the pain and stiffness, often quite quickly.
That's good to hear. Does the dose stay the same?
No. Once the symptoms are well controlled, the aim is to gradually reduce the dose, taper it down over time, finding the lowest effective dose.
Tapering down. Okay. What about things like ibuprofen, NSAIDs?
They can sometimes provide a bit of symptom relief, but they don't tackle the underlying inflammation like steroids do. Glucocorticoids, the steroids, are definitely the main treatment.
Steroids are key. Are there other drugs used?
Sometimes other drugs like methotrexate or azathioprine are considered, especially if people have trouble tapering off steroids or have relapses. But they aren't usually the first-line choice. There's limited evidence for using them right from the start routinely.
Okay. And beyond meds, what else is important?
Well, you need to think about the impact on the person's life, addressing any physical limitations, maybe involving physio, considering the psychosocial aspects too.
Right, the whole person.
And before starting steroids, it's crucial to check for any risk factors or conditions that might make steroid side effects more likely. Diabetes, high blood pressure, risk of osteoporosis.
Screening first. Good point.
And I know I keep saying it, but if there is any suspicion of GCA alongside the PMR, that requires urgent high-dose steroid treatment. No delay.
Got it. Urgent GCA treatment. So for standard PMR, you start prednisolone. What dose typically?
Usually around 15 milligrams of prednisolone daily is a common starting point.
15 milligrams daily. And how do you know if it's working?
The response is usually quite dramatic. People often feel significantly better within days. That rapid positive response actually helps support the diagnosis.
Ah, okay. And then the tapering begins.
Yes. Once things are stable, you start slowly reducing the dose according to a recommended schedule, watching closely to make sure symptoms don't return.
And how often do you monitor people?
Regular follow-up is really important. You need to monitor their response to treatment, check for any adverse effects from the steroids, and just generally track how the disease is progressing.
What kind of steroid side effects are we watching for?
The common long-term ones include osteoporosis, thinning of the bones, increased risk of infections, weight gain, mood changes, potential effects on blood sugar leading to diabetes, and also high blood pressure.
Right. Significant potential downsides. How do you manage the osteoporosis risks specifically?
That's a big one. For people considered high risk or anyone likely to be on steroids long-term, we often proactively prescribe bone-protecting medication, usually bisphosphonates.
Bisphosphonates, like alendronate.
Exactly. Often given along with calcium and vitamin D supplements.
From the start.
Often, yes, for high-risk individuals. Or we might do a baseline bone density scan, a DXA scan. If that shows significant bone thinning, say a T-score of -1.5 or lower, then bisphosphonates are usually recommended.
Okay, proactive bone protection. When would someone with PMR needs referring to a specialist, like a rheumatologist?
Good question. Referral is usually considered if the presentation is atypical, doesn't quite fit the classic picture, or if there are treatment dilemmas, like difficulty tapering steroids or managing side effects.
Okay.
Also, if the condition relapses frequently, or if any red flag features pop up suggesting something else might be going on, or a complication like GCA.
And how do you handle a relapse if it does happen?
First, always reassess for GCA. If there are any new features suggesting GCA headache, visual changes, jaw claudication, you treat it as a GCA flare with high-dose steroids immediately.
Right. Assume GCA until proven otherwise if those symptoms appear.
Definitely. If it seems like a straightforward PMR relapse without GCA features, then the usual approach is to increase the prednisolone dose back up, maybe to the previous effective dose, or sometimes a bit higher temporarily.
Decrease the steroids again.
Yes. Sometimes an intramuscular steroid injection, like methylprednisolone, might be considered as an alternative to increasing the oral dose.
An injection option.
And if someone keeps relapsing, say after 2 or more relapses, despite trying to manage the steroids, that's when adding an immunosuppressant, like methotrexate, is often considered to help spare the steroid dose.
Methotrexate for recurrent relapses.
Oh.
Okay. So treatment works well, but it can be a long road with tapering and potential relapses. What's the overall prognosis? What's the long-term outlook?
Overall, the prognosis for PMR itself is generally good.
That's reassuring.
Most people respond really well to the steroids, as we've said, with significant improvement in pain and stiffness.
How long does treatment usually last?
It varies quite a bit. Some people might only need treatment for months, maybe a year or two. Others might need low-dose steroids for longer, potentially a few years.
A few years, okay.
It's important to remember that risk of GCA developing during PMR treatment, that's estimated around 15%. So ongoing vigilance is needed.
15% risk of GCA during treatment.
Yeah. And relapse, as we discussed, is pretty common, but it usually responds well when the steroid dose is adjusted.
And does PMR affect lifespan?
PMR itself isn't directly associated with increased mortality. People don't die from PMR. However, morbidity, illness, and sometimes mortality can unfortunately result from complications of the treatment, particularly long-term immunosuppression or steroid side effects.
So the treatment risks are the main concern for long-term health outcomes.
Largely, yes. Managing those risks is key.
Right. And what are the main complications we worry about, both from untreated PMR and from the treatment itself?
Well, if PMR is left untreated or isn't managed well, the persistent inflammation could potentially lead to more joint issues, maybe even some joint damage over time, and resulting disability.
Okay, so controlling the inflammation is important for joint health.
Definitely. And then the complications from long-term steroid use are the ones we've touched on. Osteoporosis, weight gain, diabetes, high blood pressure, increased infection risk.
The usual suspects with long-term steroids.
Exactly, which is why regular monitoring and trying to use the lowest effective dose for the shortest necessary time is so crucial. Minimize those complications.
So, summing up, PMR is treatable, prognosis is generally good, but requires careful, long-term management focused on symptom control and minimizing treatment side effects, always keeping an eye out for GCA.
That's a perfect summary. The key takeaways: bilateral shoulder hip pain and stiffness, morning stiffness, 45 mins, age over 50, raised ESR-CRP, think GCA. Treat with low-dose steroids, taper carefully, monitor for side effects, especially osteoporosis.
Excellent. This has been a really clear and helpful deep dive into polymyalgia rheumatica. Really distilled those revision notes.
Glad it was helpful.
You know, thinking about this interplay between the immune system, genetics, the environment, it makes you wonder, doesn't it? What's the next big breakthrough going to be in understanding why PMR happens?
That's the big question, isn't it? If we could really pinpoint the triggers or the exact immune pathways involved, that could open doors to much more targeted therapies, maybe even prevention strategies one day. It's an active area of research.
Fascinating to think about. Well, for anyone wanting to solidify this knowledge or explore other related topics, definitely check out PassNMSRA.com.
That's PASSTHEMSRA.com.
And also FreeMSRA.com.
FREEMSRA.com. Both great resources.
Fantastic. Well, that wraps up our deep dive for today. Thanks so much for joining us.
My pleasure.